Do you know where I can find it after if I record to the cloud?
I think it automatically goes to a mill.
Okay, cool.
Is that good? Can everyone see that? Yeah. Okay. I'll wait like a few more minutes. Okay, all right, I'll just start then. Okay, so welcome to week 9. I think the topics are going to be PHYS, and then we'll follow that with some anatomy and then CLIN skills, so a bit of everything. Okay, so I'm going to start off with PHYS and just an intro into the cardiovascular system and the concept of hemodynamics. Okay, so what is the cardiovascular system? There's 3 key components of it. It's often described as kind of like the piping network or system of your body. So you have the blood, which is what's flowing through your blood vessels, which are kind of the pipes, and then your heart, which is the pump. And I think we're all pretty familiar with all of those 3 things. And then there's the functions of the CVS. So things like supplying nutrients and oxygen, you probably already know, and removing waste products, but also, as you'll come to learn over the semester and in year 2 as well, it transports things like hormones around the body and also allows white blood cells and your immune system to move to different areas when you have infections or injuries in different places. And also it's an important part of transferring heat. Now, there's 2 key circulations in your cardiovascular system. The systemic one, and that's pretty much the blood flow that's going from your heart to the rest of your body. And then there's the pulmonary circulation, and that's blood going from your heart to your lungs to get oxygen again. So with your systemic circulation, as I said, we're going from the left ventricle of the heart. And I'll show you a picture on the next page. But we're going from the left ventricle to all the organs in your body, including your heart and your lungs, back into the right atrium. And then with the pulmonary circulation, you're going from the right ventricle to your lungs and then to the left atrium. Just a note here is that the pressure in your systemic circulation is a lot greater than in your pulmonary circulation. And that would make sense because the blood that's traveling throughout your body needs to be pushed with a lot greater force so it can reach all the way down to your legs. So as I said before in the last one, this is a good picture. It didn't really fit on the last slide. But so if we look at the systemic circulation, we're leaving from the left ventricle, going into the body. This is the blood vessels in all of your body, capillaries, and then it comes all the way back into your right atrium. But then your pulmonary circuit is we're going from the right ventricle, with blood that doesn't have any oxygen or less oxygen, and that's going to your lungs, getting oxygen through capillaries in your lungs, and then coming back into the left atrium. So two things that you'll hear is that these circulations are either in series or in parallel flow. So flow in series means the blood flow is going from one place to another sequentially. So the flow from the pulmonary circuit to the systemic circulation is in series because it's going from the systemic into the pulmonary or from the pulmonary into the systemic. Whereas the blood flow that's happening in your body, so in the systemic circulation, is parallel because this blood is going into all the tissues in your body at the same time. Okay, so now we have heart failure. This is just a brief overview of it, and you're going to learn a lot more about it in upcoming lectures. But pretty much, you kind of have your left heart, so the left side of your heart and the right side of your heart. And your left heart is receiving blood from the lungs and it's pumping it into your body, whereas your right heart is receiving blood from your body and pumping it into the lungs. So when we get left heart failure, that means the left heart here is not working properly. So it's not able to pump blood into your body as good as it can or as good as it needs to. So what happens is blood starts backing up into the lungs. And a lot of your symptoms then that you get, which you'll see on the next slide, will be related to fluid building up in your lungs. So things like breathlessness and just lung breathing related issues. Whereas with your right heart failure, so on this side, blood is not being pumped into your lungs as efficiently or as strong as it could. So what happens is blood starts to back up into your body, into the veins and in your body. So then you get a lot of swelling and fluid buildup in your body tissues, which usually you would see in your ankles and feet just because of gravity. So this side is pretty good at summing up the key symptoms of left heart failure and right heart failure. So with the left heart failure, you get these things, which you probably are not familiar with what they mean. I've put in the definitions in the notes in the side, but pretty much all different types of breathlessness. As I said in the last slide, the blood is backing up in your lungs. And then on the right heart failure side, we have swelling of the ankles and congestion in your organs throughout your body, like your liver. And then also backing up into your JVP, which you're probably not familiar with either, and that's not really important. You can ignore that. But overall, just a lot of buildup and swelling in your body as opposed to your lungs. Okay, so now onto hemodynamics. There's the distribution of blood at rest versus exercise. So because different things are important when you're kind of resting and digesting versus when you're running, your blood needs to be redirected to different tissues depending on what's happening. So at rest, your blood is going towards those rest digesting things to do with metabolism like your guts and your kidneys. But then during exercise, a lot of that blood is being redirected to your skeletal muscle. I think this might have cut off down the bottom, but just importantly to note is that what's redirecting the blood flow is the arterioles dilating and constricting. So not the like big arteries like your aorta and not the capillaries, but it's the arterioles, which are kind of the middle vessels. And then, yeah, so that's pretty much what I said here. So during exercise, vasodilation of arterioles in your skeletal muscles. So we're getting more blood flow to your skeletal muscles, but then vasoconstriction of the arterioles in things like your GIT organs. Okay, so in hemodynamics, there's also the concept of flow, which is important. So flow is the pressure gradient over resistance. So pressure gradient is pretty much just in a vessel, let's say, from one point to another, it's the difference in pressure. So blood flow or anything really will flow from a place of higher pressure to lower pressure, and that's what happens in your vessels as well. And then when it comes to resistance, resistance is just the force that's opposing, any forces opposing the flow of blood in a vessel. So 3 things that will affect your resistance in a blood vessel is having a longer vessel length, so longer blood vessels, having a smaller vessel radius, so it's just a smaller space, there's more resistance, and then also having a greater blood viscosity. And we'll talk about what that means in the next few slides, but viscosity is pretty much just your blood is thicker, so it's not flowing as easily. This is an equation which is pretty helpful in learning how all of those are related. So you can kind of see how if viscosity and vessel length were greater in value, it's going to increase resistance. And then vessel radius is, if it's greater in value, it's going to decrease resistance. And just know that there is this kind of to the power of 4 relationship. So if you increase the vessel radius by by like 2 times, you're going to increase the resistance by, you're going to decrease the resistance by 16 times. Okay. So viscosity and hematocrit. Viscosity, as I said in the last one, is the resistance to flow. So a viscous liquid is kind of like honey, and it's more sticky and it's thicker. And hematocrit is just the percentage of blood that is made up of your red blood cells. And how are they related? It's pretty much if your hematocrit is too high, so if you have a lot of red blood cells in your blood, your blood will be more viscous and it'll be thicker and harder to flow. So these are just the normal-ish values in males and females. Males kind of have a higher, slightly higher value, which means they have a slightly higher oxygen carrying capacity as well. And then, yeah, pretty much here. So there's a higher hematocrit is more viscous. And that has implications. If your hematocrit is too high, if your blood is too thick and sticky, it's not going to flow as easily. So that's going to decrease flow to tissues as well as increase your clotting risk. Yeah.
Okay, so thanks, Sayumi. I'm gonna start your first part of the electrical activity of the heart. This is pretty high yield stuff, so it's important that these concepts are understood properly. Can I go to the next? Okay, so well, this is the basic structure of the heart. I think Sayumi's kind of touched on this, but basically it's got 4 chambers. You've got your right side and your left side, and then you've got the atrium and the ventricles. So right side is kind of in correlation with the lungs, and left side is with the rest of the body. Now the 4 valves: pulmonary, aortic, tricuspid, and it says aortic twice. One of them is supposed to be mitral. That's my bad. And then there's 2 nodes, which is what we're going to be focusing on today: the sinoatrial node and the atrioventricular node. So go to the next slide. If we look at cardiac conduction, what is cardiac conduction? It's basically the generation or the excitation of the cardiac tissue in a kind of synchronized, orderly fashion. Okay, so there's a lot of ways in which the heart does this, but we don't really need to know too much about how it does it. We just need to know the order of like how it works. So it starts at the sinoatrial node. These are called pacemaker cells, which start the kind of thank you for circling it, which start the potential, and they're called pacemaker potentials, right? Now it starts in the right atrium, and it spreads the potential to the AV node. Now after the AV node, it goes to the bundle of His, and then we've got the right and left bundled branches, and then also the Purkinje fibers, which have the fastest rate of conduction. Now we're going to go a bit into each step. So if you go to the next slide, actually I think there's something in between, but oh no, never mind. Okay, so we're going to go to the next step. So no, yeah, go back. Yeah, okay, this slide. Yeah, okay, sorry, one more slide. No, assume you're going backwards. I mean forward. Okay, thank you. No, okay, now go back. Okay, yeah, okay, thank you. All right, so let's start with the synovial node. It's the natural pacemaker of the heart. And how does it work? It's got specialized pacemaker cells, and the reason that the conduction starts at the synovial node is because it's got the fastest rate of pacemaker action potentials. So it spontaneously generates an electrical impulse, so it doesn't require any external stimulus. And it's supplied by the sinus node artery, which is a branch of the right coronary artery, which I don't know if you guys know what that is yet, but you will soon. Don't worry too much about the arterial supply, but mainly just the main concept is the SA node kind of functions in and of itself. So it doesn't really require like an external action potential. It creates its own potentials. So if you take a heart out of a human body, it can still beat because it's not requiring. And that's why heart transplants and stuff like that work pretty well. But regardless, let's move on to the AV node. It has the slowest conduction velocity, and this is really important. So why is the AV node conduction slow? It's slow because we need time for the ventricles to fill. So synovial node causes the action potential to start, and once it reaches the AV node, it slows down. So before the ventricles can contract, the AV node kind of pauses the excitation of the heart. And the reason is, in order to get maximum efficiency and maximum cardiac output, we need to make sure that the ventricles are as full as possible. So the AV node has like a delay, and then it goes continues into the bundle of His and Purkinje fibers, which is what allows for the contraction of the ventricles, and that's how the blood flows throughout the body. But yeah, that delay is really important to allow for filling. Next slide. Okay, so the Purkinje fibers. These are the fastest conductors, or fastest cardiac conductors, I should say. They ensure that the contraction of the ventricles is in synchrony, so they occur at the same time. They have communication with the bundle of His, which is the next stop after the AV node, and this is what causes them to kind of contract so in synchronous. Is because they come from the same point, like the left and right bundle branch. They come from the bundle of His, and then that's how it's synchronized, right? Now they have a long refractory period in order to allow for the heart to contract and then allow the process to start all over again. But yeah, the reason why they have really fast really fast conduction is because the Purkinje fibers travel through like gap junctions, which not only allow coordinated stimulation, but also a faster like output. Next slide. Okay, so this is kind of the important stuff. Apart from knowing the order, looking at the action potentials, you can kind of see the difference between a ventricular action potential and a pacemaker one. So the pacemaker one is the one, well, you can see at the bottom, the one on the right. It doesn't really look like it has a plateau phase or like a stable resting potential. Instead, it kind of looks like it goes up and down and back up and down. So that's called a funny current, and I'll talk about that in a bit. And we've also got a ventricular action potential, which looks much more standard, which you would have seen when you were doing myocyte contractions. Like you've got the low negative resting membrane potential, and then you've got a sudden increase, which is stimulated by the action potential, and then you've got the depolarization, repolarization, very normal. Compared to the funny current, it's a bit, I guess it just looks very different. So I'm going to talk about both of these now. So if you go to the next slide. Yeah, so let's talk about funny current. So called F for funny and H for hyperpolarization current. Like it's just different names for the type of current it is. But how it works is basically there's like a slow influx of sodium. And then after that, you've got a transient inflow of calcium. And then once it reaches its peak, you've got a gradual decrease or an outward flow of potassium. And then in order to keep the funny current kind of alive, so instead of going too far down, right? So you've got the repolarization with this slow calcium to influx. But what happens is you've got this repolarization through the outward K plus, which is balanced with the calcium. And what's happening is, because you've kind of got a slow ion influx and outflux, you don't get too much of a decrease. It doesn't go to like -90 or -100 like you might see in the next slide, but instead, because of this balance, you've kind of just got it going down, but then the outward flow of sodium causes the quick repolarization and initiates like the threshold potential quickly, and then you've got the sodium again coming back in. So it's slightly different, but again, it's not too important to really know steps of this. It's more or less just understanding that that in a funny current, you don't have a resting membrane potential. Instead, you have a threshold potential, which is -40, and you have ions that are keep changing, going in and out, which allows for constant, I guess, like action potentials being fired. Yeah, it's okay. And then on the next page, so this one is a bit more complicated. So myocyte contractions, probably the highest yield stuff that you're going to have in your lecture today. There's a few important steps. I guess I've described the phases here. So resting membrane potential is -90, and then you've kind of got potassium channels that are opening, ensuring a steady like efflux, but that's not too important. The rapid depolarization occurs because you've got voltage-gated sodium channels, which cause a huge influx of sodium, and that causes the membrane potential to rise from -90 all the way to +130. So it's an overshoot, right? Because for the action potential to be fired, it needs to be 0, but it's gone all the way to +30. So you've got the rapid influx of sodium, and then part 1. This is kind of the important bit. So you've got this plateau phase, right? So what's happening here is, in phase 1, you've got the partial depolarization where it goes from +30 to 0. And what's happening there is you've got chloride going out. Chloride going in and potassium going out. But the the potassium's going out faster than the chloride is going. Wait. Oh, they're both going out. So that causes a decrease, sorry. And then in the next phase, calcium channels open up. You've got these L-type calcium channels. And what happens is, when they open up, your membrane potential stabilizes, because the amount of ions that are either negative or leaving, so potassium is leaving and chloride is negative, balance with the calcium that's going in, because calcium is positively charged. So what happens is the negatives and positives cancel out, and then you've got like a neutral phase. And then what causes what that causes is a plateau phase. And then in phase 3, you've got repolarization. So after the plateau phase, you've got a calcium channel efflux. Potassium channel efflux, and you lose a lot of potassium out of the cell. And then you've kind of got, there's also something else that's really important that I forgot to mention. No, that's it. And then you've got a steady exit of potassium, and then it repeats. Now, a couple of things that are important here are knowing how sodium channels kind of work in this kind of scenario. So what happens is, the voltage-gated sodium channels open, and you get phase 1, right? So you've got the huge activation. But then what happens is, instead of closing, they become deactivated for a while. So the voltage-gated sodium channels are deactivated, and that's what kind of also helps the plateau phase occur. And then later it's closed once it's kind of repolarizing, and then it will reopen again. Okay, so the interesting thing about that is, because most other channels kind of just open and close, but the sodium voltage-gated channels have a deactivated period, and then they close. So it's just something that's a little bit different. But basically, you just need to know that sodium goes in, you get like a action potential firing, then you get fluoride and potassium kind of stabilizing with calcium, which causes the plateau phase. And then you've got lots of potassium exiting the cell once the potassium channel opens, and that's it. Now, the reason why sodium channels open first and then potassium channels open later is because sodium is a fast voltage gated channel, whereas potassium is slow. So all of the sodium, you'll get the sodium opening, deactivation, and then closure just about the time when the potassium channel opens. So it's kind of done on purpose so that you get this kind of basic shape, but yeah, that's basically all you need to know. I think that's it, right? Next, yeah.
If you want, I can share my screen.
Yeah, sure.
Okay. So I'm just gonna, not share. I'm just gonna go over the overview of the back. So these are the learning objectives that you can read through. But so the vertebral column extends from the cranium to the pelvis, and it encloses the spinal cord. And it is broken up into these 5 sections. So cervical is at the top, and then thoracic, lumbar, sacral, and coccyx. The vertebra provides support, bearing the weight of the head, neck, and trunk, and ultimately transfers that weight to the appendicular skeleton of the lower limbs. And each vertebra articulates with the neighboring vertebra through these articular processes and through intervertebral discs, which like sit on top of these vertebral bodies. The diagram on the left here is just for demonstrative purposes, but we'll see in the next few slides that each of these different regions actually has specific features for all of these. But so in a quick summary, the spinous process is always the back. So that's what you can feel when you move your hand down your spine. So that's the most posterior. And then this is connected via the lamina to the articular processes. So you have one of these on top and one of these on the bottom, so superior and inferior. And so the superior and inferior are what articulate together in this zygophyses joint. And then you have the pedicle that connects this to the vertebral body and the transverse process. So on just here, we can see that there's 7 cervical vertebra, and some specific features for cervical vertebra are that they have a triangular vertebral shaped foramen, and that their transverse processes are the only ones that have these transverse foramina. And you'll learn that the vertebral artery, which goes up to supply the head as well, runs through this. And so that's pretty important in case of any like fractures or broken bones through here. Its spinous process is also fork shaped, which is called a bifid. So the C1 and C2, so the highest 2 cervical vertebra, are a bit unique. So the C1 articulates with the occipital condyles of the cranium and it's superior through its superior articular facets just here. And it has the largest vertebral foramen of any vertebra, because this is like where all the spinal cord is arising from the brain area. And then this C2 is characterized by the presence of a tooth-like odenoid process. So the dens, this is it here. And so this dens is actually originating from this C1 body, but it ends up joining to the C2 and unjoining from the C1 and is held by this transverse ligament here. And that's what allows your head to rotate on your body. And the C3 and C6 are just typical cervical vertebra. And then the C7 has a long slender spinous process. And this is the one that you can palpate at the back of your neck. So just like a quick question, the cervical vertebra has the smallest vertebral body because they only have to support the weight of the head. So from this, what could we conclude would be the largest vertebral body, and it would be the lumbar because they have to carry the weight of like the head, the upper limbs, and the torso and abdomen. So moving on to the thoracic, there's 12 thoracic vertebrae, and their vertebral shape is a bit circular, and their transverse processes are long, and they contain articular facets for the ribs. So that's something only unique to the thoracic vertebra. And their spinous processes are long and point inferiorly. Sorry, I don't know why that is contradictory, but it's actually, yeah, I was going to say it's actually heart-shaped vertebral bodies, as you can see just here. T1 to T8 has a superior and inferior costal facet, while T9 to T12 only has one single costal facet on each side. And then moving on to the lumbar, there's 5 vertebrae in this area, and they have a flattened triangular shaped vertebral body, and their transverse processes are short with no facets or foramina, and their spinous processes are thick and point posteriorly. So yeah. And then moving on to sacrum and coccyx. So the sacrum is actually like 5 different vertebrae, but they fuse by adolescence, into this immobile wedge-shaped bone. While the coccyx is this tiny little bit on the bottom, and it is the fusion of 3 to 5 variable segments. This is like pretty low yield, it's just like a little fun fact, I think, but in males, it points anteriorly, while in females, it points inferiorly, and that's based on like giving birth and like the location of hips and stuff like that. So moving on to the curvatures. So the thoracic and sacral curves are called primary curvatures. So that's kyphosis, because they appear late in fetal development and they form a C-shaped, while the lumbar and cervical are known as lordosis. And I think that's like pretty self-explanatory. So like if you're like sitting in there in the exam, you can think like your cervical spine goes this way and then your thoracic goes the other way. So it kind of forms a backward S shape. And then the intervertebral discs, which are just here. So this is what I was saying before, sit in between the vertebra, and they're composed of the nucleus pulpus and the annulus fibrosus. And this is pretty important because they obviously stop like friction between the vertebral bodies. So if this like wears out over time, and this can cause a lot of pain, I'm just checking. Yeah, this can cause a lot of pain. And you'll also learn that there's a lot of clinical conditions relating to this. So such as like if a tear in the annulus fibrosus occurs, then the nucleus pulpus can like leave and it can push on the spinal cord, like the nerves leaving the spinal cord. So there's a lot of different things that can affect this clinically. Moving on to the ligaments. This anterior longitudinal ligament is, if you're imagining, at the front of your body and connects at all the vertebra along its anterior surface. And then this posterior ligament runs down the back of all the vertebral body. You have the ligamentum flavum running between the lamina of adjacent vertebra. And I couldn't get the ligamentum nuchae in this photo, but it essentially like connects from like the base of your skull kind of thing down to C7. And it's like a very broad ligament. And then, yeah, otherwise, this is pretty self-explanatory, I think. Like if you read the names, they pretty much tell you where they are. So anterior longitudinal obviously runs down the anterior, and like intertransverse, it's obviously running between the transverse processes. Interspinous is running between the spinous processes. So yeah. So moving on to the movements of the back. So you have flexion, extension, lateral flexion and extension, and then rotation. And with this rotation, you can have like independent rotation of the head or like joint rotation. So yeah, and I remember this table was like told to us that it was pretty high yield, but I can't remember like any questions on it, but probably like that's just like explaining how the movements occur based on the like articular joints between each of the vertebra. But so with this, the intrinsic muscles of the back, I can't stress enough, like you don't have to memorize these as much as you do the upper limb and lower limb. And it's just like to try and focus on the big picture, like what movements they help to control. And this third column is innervation, but I think like it's pretty easy one to remember because they all are the posterior rami of wherever they're like located close to. So just moving on, I've got a photo on the next one. So the splenius muscles are the most superficial. They're only in the cervical region. And as you can see, like with the orientation of these fibers, they help to extend the neck, laterally flex it and rotate it. And obviously that is based on whether you have unilateral or bilateral contraction of those muscles. Next, you have the intermediate layer, and this is made up of the spinalis, longissimus, and iliocostals. And as you can see, like when these muscles contract, it's obviously going to be a major extensor of the vertebral column. Next, you have the deep, which are these two ones here, and these are the major deep muscles, or these are the minor ones. So as you can see here, like these muscles only contribute to slight extension and rotation of the vertebral column, and same with these ones. But for a few tips to remember them, the splenius muscles are the only ones to contain a C, so you know that these are in the cervical region. Inter means that they're running between, so the interspinals, you can see are running between the spinous processes. The intertransversi are running between the transverse processes. And you can see that all intermediate muscles, so these ones just here, arise from the common tendinous origin near the sacrum. So they, wherever they're starting from, you know that they're all going to run down to this sacral region. And all major deep muscles insert on the spinous processes. So just here, these two. So yeah. And then these are the extrinsic muscles of the back. And this is pretty much revision from upper limb. So I won't spend too much time on this. You have your rhomboids, your levator scapular, trapezius is your big muscle along here, latissimus dorsi around the side, and same as serratus posterior. So for a few pathologies, you can have a cranial shift or a caudal shift in your ribs coming off your vertebra. So in cranial shift, it's where the cervical rib articulates with C7 instead of starting on the T1. And obviously if you're relating this to pathology, it could like cause thoracic outlet syndrome or stuff around there. Whereas in the caudal shift, it's as if they move one down. So rib 12 is large, and then you have a littler rib on L1. Spina bifida, I think you'll do an RCL on this, but this is a folate deficiency. And depending, there's 3 different types. Occulta is like the least severe, whereas myelomeningocele is the most severe because you have these spinal nerves budding out, obviously, which is going to cause some problems. And then this relates to the curvatures that we were talking about before. So kyphosis is when the thoracic curve becomes exaggerated posteriorly. So you can see this. So I think like kyphosis, if you're thinking thoracic vertebra, you're thinking like an old person like hunched over, whereas like lordosis is excessive anterior curvature of the lumbar spine. And it's, I think it's pretty good with these ones because like L, you can say lumbar, and then that helps you narrow it down to where it is. And scoliosis is curvature of the vertebral column in the lateral way, so it's not anterior or posterior. And these are some other things that you'll have to learn. So if you're doing anything into the spinal cord, such as like giving a local and like anaesthesis for childbirth, would be something where you're doing epidural. But so a mnemonic for remembering these layers of the spinal cord is 3SILEDAS. This is in the comments below. But so first you have the skin, and then you have the superficial fascia, supraspinous ligament, interspinous ligament, ligament of flavum, epidural space, which is what we're getting to here, dura mater, arachnoid, and subarachnoid space, and that is what is containing the cerebrospinal fluid, and then you would get to the spinal cord. Except you don't actually ever want to like really get the needle onto the spinal cord, because if you like damage those nerves, that'll be a problem. So you're always trying to get into these spaces. So the CSF, so a spinal tap is when you draw in cerebral spinal fluid from the subarachnoid space, whereas an epidural is when you're giving local anesthetic. And so now I'll pass on to Jordan.
Were you going to do the special test for the back? Or are we going straight to CVS?
Sorry, I forgot I had another slide.
Oh, no worries.
Share. So for the special test of the back, I didn't want to run through the whole examination because I think like it's written in your books anyway. So I'll just be repeating what you can read from the book. But for the special test, the Schober's test measures lumbar flexion, and it may indicate ankylosing spondylitis. The femoral nerve test stretches the femoral nerve, and the straight leg raise test, Sprague's test, and cross leg raise test all stretch the sciatic nerve for any nerve irritation. So all these tests in the back are trying to elicit, like find out which specific nerve has been affected. But yeah.
Right. One sec, I'll share my screen. Cool. So today I'll be talking about cardiovascular history as part of clinical skills. So as you've learned before, the systems review is a series of questions which you ask about a specific system after all the WWQQAA stuff, right? So for the cardiovascular system, the questions include chest pain, dyspnea, which is shortness of breath, paroxysmal nocturnal dyspnea, or otherwise known as PND. That's when you have attacks where you wake up short of breath at night. And also orthopnea, which is another type of shortness of breath, where you have difficulty breathing while lying down. Pedal edema, so that's swelling around your ankles. I'll talk a bit more about that later. Palpitations, when you can feel your heartbeat, but there's also several other ways to ask that so the patient knows what you're talking about. Intermittent claudication, that's pain in your calves when walking. Syncope, so fainting. Fatigue, tiredness, lethargy, anything of that. And also don't forget your systemic questions, so fevers, night sweats, and weight loss. Okay, so chest pain. There are several types of chest pain that all could indicate a cardiovascular problem. So if your patient has dull, tight, or crushing chest pain, it's likely ischemic, which means there is reduced oxygen supply to the heart muscles. And it can be further differentiated into angina, which is, you can see on the picture, is a narrowing of the blood vessels that supply your heart muscles. Usually this type of chest pain will relieve itself by resting. Whereas if you have an infarction, the blood vessel supplying the heart muscle is supplying the myocardium is completely blocked off. And you'll have prolonged chest pain. You'll also get sweating, and a feeling of impending death, they're often described. This may also radiate to the left arm and neck due to referred pain from the nerve roots C3, C4, and C5, which is the phrenic nerve. And if you have tearing or ripping pain or sharp pain, that is more likely to be a dissecting aortic aneurysm, as seen in the picture on the right, lower right. And usually it radiates to the back as well. Some other non-cardiac possible causes for chest pain may be MSK, may be pulmonary, neurogenic, psychogenic, or may even be some reflux. So you got to ask those questions as well, as you'll learn later. Shortness of breath. So there's three main types of difficulty of breathing. that you ask in the systems review for the CVS. Dyspnea, or otherwise known as exertional dyspnea, is shortness of breath upon exertion. And this is, as Sayumi talked about a bit earlier, where the pressure in the left heart causes fluid or blood back into the lungs. That causes a shortness of breath. Paroxysmal nocturnal dyspnea are episodes of shortness of breath that wakes the patient up at night. This is due to the fluid collecting around the lungs when the patient's lying flat. And orthopnea is shortness of breath when lying down. So usually to ask patients about these symptoms, you wouldn't use these terms. You just ask them how many pillows they sleep on, right? Because if they sleep on more pillows than they used to, usually means that they're getting short of breath while lying down. So they have to prop themselves up more so that they don't get as short of breath. And orthopnea is usually preceded by PND. Pedal edema, so ankle swelling, otherwise known. If it's a cardiac cause, it's, again, as Sayumi talked about a bit earlier, due to right heart failure, as there would be back pressure into the systemic circulation, creating fluid overload that pushes fluid into tissues. And for cardiac causes of pedal edema, the edema would be pitting, so it would leave a pit after you press it down for a certain amount of time because of its fluid nature, right? Palpitations, so it means the abnormal awareness of one's heartbeat. But patients might not understand what palpitations are, so you can always ask them about if they feel their heart racing, fluttering, or if it's beating faster than normal. And it may be caused by arrhythmias or other factors such as anxiety, exercise, and chemicals such as caffeine. Intermittent claudication. So this is pain in patients' calves, which when they walk over a distance, they'll feel pain in calves and they'll have to stop. And the pain is usually relieved by rest. You can ask patients if they've noticed changes in their ability to walk over a distance, like if they used to be able to walk, say, 500 meters, now they only walk 100 meters and they have to stop. That could be a sign of intermittent claudication. And the pain due to claudication is relieved by rest. And the specific reason they get this calf pain is because of a plaque forming in the peripheral arteries in the lower limbs region. And another symptom is fatigue and syncope. Both are quite non-specific, so they could also be neurogenic or psychogenic. As for cardiac causes, fatigue and syncope are both due to reduced cerebral blood flow. So blood flow to your brain is limited because of reduced cardiac output. And patients may also describe lightheadedness. So usually for syncope of cardiac causes, it's a rapid onset, but also a spontaneous recovery. And that's because usually when they fall down, the blood flow to their brain increases again, which means they'll regain consciousness. Risk factors to that predispose patients to cardiovascular diseases include their male gender and also postmenopausal women, increased age, past history of cardiovascular disease, so things such as heart attacks, so AMIs, acute myocardial infarction, Ischemic heart disease, strokes, or coronary artery bypass grafts, which is a surgery to repair clogged up arteries in your heart. Family history of heart conditions could also be a risk factor, especially if the condition was caused death of a first-degree relative younger than 60. So that's very high risk. Hypertension, so high blood pressure, high cholesterol and lipids in your blood, hyperlipidemia. Diabetes, chronic kidney disease, smoking makes your blood more viscous. Obesity, a sedentary lifestyle, high-fat diet, or stress can also lead to cardiac problems. Raised homocysteine, I think I might have a note on that. And erectile dysfunction. So raised homocysteine, it causes endothelial dysfunction. So endothelium lines the inside of the blood vessels. And erectile dysfunction may also suggest endothelial dysfunction. Right, so here are some common pathologies and the symptoms that they may present with. Aortic stenosis is where you get a narrowing of the aortic valve, right? And that would cause SAD, or the combination of syncope, angina, and dyspnea. This is due to reduced cardiac output because the left heart pumps into systemic circulation, and you'll get these symptoms if that output is reduced. Ischemia, cardiac ischemia can cause chest pain, syncope, and peripheral ischemia can cause intermittent claudication. Heart failure, you'll get dyspnea, shortness of breath if you have left heart failure. So that goes back into the lungs, or ankle swelling if you have right heart failure, which goes back into systemic circulation. And arrhythmias, you'll feel palpitations, or the patient will feel palpitations because the heart's beating at an irregular rhythm. And that concludes the presentation. Hope you enjoyed it. That's it for this week. If you have any questions, you can find me on FB or Facebook. Thank you.